minutes plus 3 minutes. Dr. Sharat Chandra, Professor of Cardiology at Lari Cardiology Center, King George's Medical University, Lucknow. Professor Chandra, please.
So my topic is cardiometabolic syndrome and its novel therapeutic approaches. So what is cardiometabolic syndrome? It is a combination of metabolic dysfunction mainly characterized by impaired glucose tolerance, dyslipidemia, hypertension and central adiposity. And this cardiometabolic syndrome is now recognized as a disease entity by the World Health Organization and the American Society of Endocrinology also. And what is this cardiometabolic risk? Cardiometabolic risk represents the overall risk of developing type 2 diabetes or cardiovascular disease, which is due to a cluster of modifiable risk factors. And central adiposity is a major contributor to all of this cardiometabolic risk. Different guidelines and diagnostic criteria are there, like new International Diabetes Federation classification, this is 2005, and then WHO and NCP ATP3 criteria. All criteria have four things in common: that increased abdominal girth, dyslipidemia, blood pressure, and impaired glucose tolerance, except the WHO, which will involve microalbuminuria also. This abdominal obesity is linked to multiple cardiometabolic risk factors. Patient with abdominal obesity often presents with one or more additional cardiovascular risk factors. Around 86% of abdominally obese patients had at least one or other metabolic risk factor. If you see this slide, when there are one or two risk factors are present, then hazard ratio for cardiovascular disease is 1.7. But if it is metabolic syndrome more than 2 plus, then hazard ratio for cardiovascular disease is 2.7. And this increases with development of diabetes as well as cardiovascular disease. And to assess the intra-abdominal obesity, the simplest measure is waist circumference. Here you can see in this slide that the intra-abdominal assessment of fat by CT correlates very well with the waist circumference. And this intra-abdominal obesity is a major contributor of the cardiovascular metabolic risk because it increases free fatty acids, it increases the secretions of adipokinin and decreases the secretion of adiponectin, and is associated with inflammatory markers also. All of these contribute to dyslipidemia, insulin resistance, and increased inflammation, and leading to increased metabolic risk. And abdominal obesity is directly related to the risk of cardiovascular event. You can see in this slide, in the HOPE study slide, the cardiovascular death, MI, all-cause death, they all increases with the increase of the obesity. And this abdominal obesity also predicts outcomes such as sudden cardiac death. Here you can see in this slide in the left side, this is sagittal abdominal diameter. It correlates very well with the risk of sudden cardiac death, whereas in the right side, it is BMI is not correlating well. Here you can see up to the fourth quintile, the graph is flat, where it is rising around from the fifth part. Whereas in the sagittal abdominal diameter, it is started rising from the first quintile. So this in Paris prospective study showed that abdominal obesity is a better marker for sudden cardiac death than the body mass index. And this cardiometabolic, this is the slide from the Inter-Heart study. It is showed that risk of first MI, the risk factors for first MI are abnormal lipids, smoking, and third one is abdominal obesity, followed by hypertension and diabetes. So abdominal obesity is contributing more for MI than hypertension and diabetes. And this slide shows that development of diabetes with the increase of the waist circumference. And this is slide showing intra-abdominal obesity and glucose metabolic link. Here you can see the green graph is level of glucose, and in obese patient with low intra-abdominal fat, whereas the red one is obese patient with high intra-abdominal fat. The sugar levels are high glucose levels are high in the obese patient with high abdominal fat, but the level required to treat such glucose is the level of insulin is remarkably high in subjects with obese patient with high intra-abdominal obesity in comparison to obese with low intra-abdominal obesity. And the treatment of cardiometabolic risk is basically risk factor management to minimize the risk of diabetes and cardiovascular disease. The lifestyle measures, everybody knows that weight should be maintained, we should decrease the salt intake, limit alcohol consumption, physical activity should be increased, and for obesity, drugs like phentermine and sibutramine are no longer in use. Absorption inhibitor orlistat is also not a very common drug. Bariatric surgery is an option for patient when the BMI is more than 40 or when the BMI is more than 35 with comorbidities. Dyslipidemia, the goal of TG should be less than 150. For LDL, it should be less than 100. For very high risk patient subject, LDL should be less than 70. And for SDL, the goal is more than 40. why the diabetes control is so important because for every 1% rise in HbA1c, there is 18% risk in rise of cardiovascular events and 28% increase in the peripheral artery disease. And premature CVD is the main cause of death in type 2 diabetes. So now evidence is accumulating to show that tight blood sugar control in both type 1 and type 2 diabetes reduces the risk of cardiovascular disease. And to overcome insulin resistance and diabetes, multiple treatment options are already there, like insulin sensitizer in form of biguanides or PPR gamma agonists, insulin secretagogues like sulfonylurea and maglitide, and finally insulin. And for hypertension, multiple risk factor intervention trial and Framingham Heart study showed that increased risk of CVD with long-term sustained hypertension, and it also demonstrated that a 10-year risk of cardiovascular disease in treated patient versus non-treated patient is around 0.4%, and there is 40% reduction in the stroke with control of hypertension. So what are the new treatment options for metabolic syndrome? So new class is basically SGLT2 inhibitors, and the important drugs are empagliflozin, canagliflozin, dapagliflozin, and these trials have showed trials of these drugs have showed significant reduction in cardiovascular disease. So this is the one very important slide from EMPA-REG outcome trial. In this trial, patients with type 2 diabetes at high risk for cardiovascular events were randomized to 1:1 fashion with EMPA 10, 25 or placebo, and they were followed for 3.1 years. And the trial concluded that EMPA SGLT2 inhibitor is superior to placebo in improving glycemic control and reducing cardiovascular events in patients with diabetes and established CVD, including mortality benefit. This is one of the largest scale trial of diabetes to show an improvement in cardiovascular outcomes with simultaneous improvement in glycemic control. And this one DECLARE-TIMI trial, it also showed that patients with type 2 diabetes at risk for atherosclerotic CVD, treatment with dapagliflozin did not result in higher or lower rate of MACE than placebo, but did result in lower rate of cardiovascular death or hospitalization for the heart failure. And this is CANVAS trial slide. Is canagliflozin was tested in diabetic patient, and it was to show whether this canagliflozin reduced cardiovascular mortality, non-fatal MI or non-fatal strokes when compared to placebo in patient with type 2 diabetes mellitus. And this CANVAS trial showed that canagliflozin reduces the risk of cardiovascular events, renal decline, heart failure, hospitalization, but it increases the risk of amputation in patient with type 2 diabetes mellitus with high cardiovascular risk. This is another new class for cardiometabolic syndrome, the GLP-1 agonist, glucagon-like receptor agonist. FDA approved 4 drugs, liraglutide, semaglutide, dulaglutide, and elbeglutide. Elbeglutide is now out of market because of an economic issue from the company. And it's lira, sema, and dula are in injectable form except semaglutide, which is also in oral form. And these trials of these drugs have demonstrated significant reduction in cardiovascular events, and GLP-1 receptor agonists were additionally found to benefit in patients with microalbuminuria. This is a trial of liraglutide, LEADER trial. It showed that in addition to common drugs of diabetes, trial showed the rate of first occurrence of death from cardiovascular causes, non-fatal MI or non-fatal stroke among patients with type 2 diabetes were lower with liraglutide than placebo. And this is a SUSTAIN 6 trial. It showed in this trial semaglutide was tested in diabetic 2 patients, and patients with diabetic 2 patient at high risk of cardiovascular events were randomized to one fashion with semaglutide or placebo, and they were followed for a median of 2.1 years. And the trial showed that injectable once a week semaglutide was superior to placebo in improving glycemic control and cardiovascular events in high risk patients with diabetes. And there is also significant reduction in stroke and new or worsening nephropathy with semaglutide, perhaps related to a concomitant weight reduction and also reduction in the BP. This is Pioneer 6. Here the drug tested was oral semaglutide. Earlier the semaglutide in SUSTAIN 6 was injectable. Here is the drug is oral semaglutide in diabetic patient, and this trial showed that MACE events decreased significantly in semaglutide as compared to placebo, and the glycolated hemoglobin levels and body weight decreased significantly with the semaglutide. This is another new one class is GIP and GLP-1 receptor agonist combined agonist. The dual glucose dependent insulinotropic polypeptide GIP and glucagon-like peptide GLP receptor tirzepatide was tested in multiple trials, and the trial involves all SURPASS trial 1, 2, 3, 4, 5, where this tirzepatide was tested with again multiple drugs like semaglutide, insulin, placebo, and they showed that it is an effective treatment to improve glycemic control in patients with type 2 diabetes. This is another new drug, canakinumab. It is a This has been tested in Cantor's trial. It is a monoclonal antibody against interleukin-1 beta, and the trial showed that a dose, canakinumab at a dose of 150 milligram every 3 months led to a significant lower rate of recurrent cardiovascular event compared with placebo, independent of its lipid-lowering effect. This is trial from LODOCO 2 trial. LODOCO trial, either colchicine was tested in the chronic coronary syndrome, and the primary outcome like cardiovascular death, spontaneous MI, ischemic stroke or ischemia-driven revascularization was less in the colchicine arm, whereas there was no difference in the cardiovascular mortality, non-cardiovascular mortality and all-cause mortality. So this is a new hormone, esprosin. Basically, it is a hormone which stimulates appetite and increases blood glucose level by acting on the hypothalamus and the liver. And the monoclonal antibody against this decreases the esprosin level, which leads to production from metabolic syndrome by suppressing appetite and blood glucose. This is in the experimental phase. And coming to the last slide, it is a gene therapy for metabolic syndrome. So multiple genes which has been tested for lipid metabolism are like PCSK9, ApoC3, ApoA1, PPRA gamma and MCP1. And the most work has been done on the PCSK9. This is pro-protein convertase substitution connexin type 6. And the technology which is testing this PCSK9 gene is CRISPR technology. So CRISPR is another promising way to knock down PCSK9 levels in the human liver once or all. And CRISPR-based editors, they encouraged a significant reduction in the plasma level, PCSK9 level, and higher reduction of plasma LDL level in experimental models. Thank you.
Time for questions.
Any questions from the audience regarding this topic?
We talked about SGLT2. Yes, sir. Any contraindication of use or any drug interaction?
Basically, renal failure is like contraindication. When the GFR is too low, then we should avoid.
One commonly missed thing is it should not be used with insulin. People are using it, but I don't know. Any clarification from any person? Dr. Khera? It should not be combined with insulin.
Any comments from panelists?
Okay, Mr. Chairman, do we have any further questions? If not, okay, if that be the case, then we'll call the session to a close. We'd like to thank the chairpersons, the members of the expert panel and the faculty for enlightening the audience. Thank you very much, chairpersons. Ladies and gentlemen, we move ahead with the orations.